Hello, everyone. We're going live in a couple seconds.
Nicole is already live on YouTube. That's what my notice is telling me.
Sorry, was it? Oh, we're live now?
You want to include the participants? That might be safest then. Do it now. Dr. Davidson needs to come online then. Her camera is still off. Let me take a pic so that I can tweet it.
right, everybody, look at your camera and give a nice smile.
Oh, yeah, she's right.
Perfect.
Hello, good afternoon, everyone. Welcome to the NCD and COVID Part 2 webinar entitled Vulnerable Populations. My name is Nicole Bovell-Arthur of the IT Department of CARPHA, and I just wanted to go through with you how you communicate with us during the webinar. So to the bottom of your screen, you'll see, when you move your mouse close to the bottom of your screen, you'll see a Q&A button. And this is where you will ask questions for our panelists. However, if you have questions that are of the nature of, will we get access to the recording? We invite you to use the chat feature right next to the Q&A. Your moderator for today's session would be Ms. Carlin Curtin. So we now hand over to Ms. Curtin, who will be with us for the rest of the session. Thank you for joining.
Good evening, everyone. CARPHA is really pleased to welcome you to our health. This evening, we are going to discuss another important topic within the context of COVID-19. As you may know, today is World Stroke Day, and CARPHA is proud to help to raise awareness about stroke, especially today. This evening, we talk under pressure, NCDs and COVID Part 2, vulnerable populations. In keeping with World Stroke Day 2020, join the movement to prevent stroke. We have a panel of experts who will share current understandings, lessons learned, and interventions to support the medically and socially vulnerable populations during the COVID-19 pandemic. Our esteemed panelists will cover topics on tracking COVID-19 and NCD deaths in the Caribbean, COVID and cardiovascular diseases, nutrition and exercise, all from a Caribbean perspective. I will introduce you to these esteemed panelists as they present to you. I am Carlin Curtin, Communications Manager at CARPHA. We're live, ladies and gentlemen. We're streaming on YouTube and Facebook. But before we start, I want to reinforce what Nicole just said to you and encourage you to post any questions that you may have into the Q&A. Panelists, feel free to respond to questions directly into the chat as you see fit and as you may deem appropriate. We have a packed agenda, so I'm not going to delay anymore. In fact, I'm going to invite to open the innings with a World Stroke Day message, our Executive Director of CARPHA, Dr. St. John. Dr. St. John provides leadership and direction to CARPHA in executing the functions laid out in the Intergovernmental Agreement. Along with the CARPHA team, Dr. St. John has led the public health response to the COVID-19 pandemic in the CARICOM region, Prior to joining CARPHA, Dr. St. John was Assistant Director General of the World Health Organization with direct responsibility at the WHO for climate and other determinants of health, and was the first Barbadian to be Assistant Director General. She was also the former Chief Medical Officer of Barbados, first Barbadian, I must say, to hold that office for over 12 years with responsibility for the oversight of the management of the health sector. Dr. St. John was also the first Caribbean person to hold the role of Chairman of the Executive Board of WHO from 2012 to 2013. I introduce to you, and I'm very pleased to introduce to you my Executive Director, Dr. Joy St. John.
Thank you very much, Madam Moderator. And I hope you all can hear me. There is a torrent of rain. There's been a torrent of rain in Barbados the whole day. So, stroke can affect people of any age. It can happen to anyone at any time and anywhere. A stroke happens either when the blood supply to part of your brain is cut off because of a blood clot or because a brain artery ruptures and leads to a hemorrhage. But strokes happen for different reasons in children and adults. Strokes in children are often associated with existing conditions, most congenital heart disease, sickle cell disease, and infectious diseases. Worldwide, 1 in 4 adults will have a stroke, and this condition is the leading cause of death in adults in the Caribbean. However, according to the World Health Organization, 80% of strokes are preventable. A person increase their risk of having a stroke by being physically active, not smoking, reducing alcohol consumption, eating a healthy diet low in salt, sugar, and saturated and trans fats, maintaining a healthy weight, and reducing levels of bad LDL cholesterol. Most importantly, half of strokes are linked to high blood pressure, while diabetes increases your risk for strokes. The region of the Caribbean has some of the highest prevalence of risk factors for stroke. It is critical that in order to reduce your risk of a stroke, that you know your numbers: blood pressure, cholesterol, waist circumference, body mass index, and blood sugar. If you have diabetes or hypertension, try your best to ensure that it is under control. In ability from a stroke, we all need to recognize the signs and symptoms: facial drooping, arm weakness, speech difficulties, sudden imbalance, and/or vision loss. And we must make every effort to get the stroke sufferer to the hospital within 24 hours, as this is a critical step towards getting proper treatment for someone who has had a stroke. Recalling our commitment to achieving our targets and mandates to reduce premature mortality from strokes by a third by 2030, Caribbean governments, civil society, and all stakeholders have to do their part to ensure that public health programs are in place to prevent and treat stroke and its risk factors. This year's World Stroke Day, which is being observed today on the 29th of October, seeks to raise awareness of stroke and about the importance of physical activity in preventing strokes. So come, join the movement to prevent stroke. Power through collective action. Thank you for your attention.
Thank you, Dr. St. John. We truly appreciate those critical reminders that were contained in that message. At this time, I am pleased to invite Mrs. Angela Hinds, CARPHA Senior Technical Officer in the Health Information, Communicable Diseases, and Emergency Response Department, to address you on the topic, tracking COVID-19 and NCD deaths in the Caribbean. Mrs. Hinds has been working at CARPHA and the former agency CARAC for over 25 years. She's responsible for managing the morbidity and mortality data housed across several databases in the division. She also works collaboratively with the Ministries of Health and CARPHA member states and also global partners such as WHO, CDC, Centers for Disease Control and Prevention, and the European Union in strengthening strategic information systems such as mortality and HIV. I welcome and invite Mrs. Angela Hinds to address you.
Thank you, Carlin. Good afternoon, ladies and gentlemen. I'm just going to share my screen. Just give me a few minutes here. I might get it shared. So today I was going to focus on the Caribbean, but given the the focus on mortality data, there's not that much Caribbean data in terms of, comorbidities and the details that are needed. So we're going to look a little wider in the global sphere and then compare, and then we'll use that information going forward once we have that Caribbean data available to us. And as I said, it's Caribbean data with respect to mortality and these very detailed specifics that you'll see in the presentation as I go along. So we'll look at the utility of, of COVID-19 mortality data today. I'll cover mortality measurements for monitoring, comorbidity and mortality, and the certification of COVID-19 deaths. So as we would know, the purpose of collecting data would be for daily numbers of COVID-19 cases and deaths are essential in understanding the transmission. And generally, routinely, we want to have a clear epidemic profile of the epidemic, be it by a country or by region or even what's happening in a particular city. We want to monitor the effects of any interventions that we do. And with this information, it will help to guide the loosening or the tightening of the measures that are being implemented in terms of managing the epidemic. Data must be accurate. One thing we must know is that data must be accurate. The availability of data does not necessarily always guarantee quality because it may be incomplete. And the source does not guarantee good quality data. Sometimes hospital statistics may be some misdiagnosis or just again, incomplete or inaccurate. Then there is a reality then that if you have poor quality data, it will lead to poor decisions and of course, lost opportunities to improve population health. So that's the general things we must remember about the data that we collect. So I've selected some mortality indicators to look at, and these are by no means all that one would use. There would be, your general crude mortality rates, your infectious fatality rate, other things. But I've chosen these because these are the ones that we see regularly in our news media, on social media that come to us. And so, I thought I'd just go over them just to give us some insight of how these can be used. So if we look at numbers alone and you look at totals, we see that CARPHA member states, as of today, actually, I took this data today, we have 1,029 deaths within our member states. And in the wider Caribbean region, which includes our member states, we have 4,421 deaths. So at a glance, we can see what the mortality is like. And if you remember the days that went before, then we could probably remember whether these figures are going up or down. However, if we graph the new cases, which would be the daily cases, case totals, we can see have a different picture. We see that in the early stages, the rates of increase, it was the number of deaths that were gradually increasing. And then as we got on to the July and August month, we see that they are sharply increasing. So again, daily deaths given us graphed are giving us a different picture. If you look at the case fatality rate now, which is something that we see regularly in some of the world statistics that we get, as well as reported on news, etc., we see it's a ratio between the confirmed deaths and the confirmed cases during a specific period of time. But then there are limitations to this, and that these limitations should be acknowledged. So with respect to the limitations, during an outbreak, evolving outbreaks can often have a pattern of decreasing case detection and death detection over time. So as the system becomes wary and people are less likely to go out, or there are shortages in terms of testing equipment, you may find that you have a decreasing pattern. And so therefore the CFR needs to be taken into consideration, because a low detection rate will lead to overestimating of the fatality rate. And likewise, if you have a lag in the death reporting or undercounting, this would lead to underestimating the fatality rate. So this should be considered. The CFR is best valid at the end of an epidemic, really, when you have your most accurate counts of the number of deaths for the particular period of time, and the number of persons that have been affected overall for the same period of time. But it's a good measure. It's useful when you see a change. And so, for example, if you have a drop in the result, this could be as a result of several things. Your deaths may be increasingly underreported. You may have testing that is increasing, and you may have a genuine drop in your infectious fatality rate. So, you need to, so the CFR does have value when you look at it over time, and it causes you, when you see a change, to do further investigation. Let's look at excess mortality, which has become something that is more regularly used now to really get an idea of the profile and to see what's happening in terms of mortality and who is at risk. And so excess mortality is the number of deaths from all causes compared to the average over previous years for the same time period. So take a look. So if you look at this graph, again, we're looking at excess mortality here. And for these countries, we knew Spain, when they had their outbreak there, you see a steep peak. And likewise for England, you see another steep peak when there was the outbreak. And this is looking at, it's saying that during the months March 11th, April 30th, there was 140% more deaths recorded than in previous years during that same period, March to April. So that's how these graphs are interpreted. And as we can see here, it was 140% increase. So that definitely an indication that something is happening. If you break it down and we look at the same type of information, but look at it from an age group point of view, we see again here for Spain, a spike of 150%, showing that for the 85 and plus aged persons, there were more than 150% more deaths than would have been expected for the same period in the past years. So we see straight away the 85 plus are adversely affected, as compared with the 15 to 64 age group, which were not as much affected, but yet experienced over 50% increase. So let's look at the US test case, and then we can see how we can best interpret some of the information we see. So this was coming from the CDC, and they reported from January through to October 3rd, almost 300 persons died in the US, and the proportion attributed to COVID-19 was 2/3 of excessive deaths. So of the excess deaths, 2/3, about almost 200,000, were due to COVID-19. When they looked at it by age group, they found that in terms of counts, the lowest number in terms of the excess was 841 for the under 25, but the highest was for the 75 to 84, which we have been seeing the trend and we've been hearing about, of 94,000. And that average percentage change in deaths over this period was largest really for the 25 to 44, which is 26.5%. Among persons aged 25, it was 2%, which we've been hearing. The under 25s and younger ones, less affected in terms of deaths. When we looked at it through the lens of race and ethnicity, we see low of approximately 3,400 excess deaths among the American Indian and Alaska Natives, and a high of almost, over 170,000 among the white persons. However, if we then just look at the ethnic subgroups and we look at see what was their expected increase, we find that actually 53.6% excess deaths were seen among the Hispanics, 36.6% among the Asians, almost 33% among Black persons, And really down at the bottom was 11.9% average for whites. So the excess deaths really seen in the Hispanics when you look at it from a proportional point of view. Whereas previously, the numbers showed that it was definitely the whites in the highest bracket. There are a number of limitations to the CFR, and as they outlined here. Their reporting labs is probably the biggest issues, and underestimation due to misclassification of COVID-related deaths. And we'll talk a little bit about the misclassification going forward. Now, let's look at comorbidity and mortality. We know that when reviewing comorbidity data and fatalities, it gives better understanding of the risk factors for death. We know that the severity of COVID-19 complication increases with the presence of pre-existing conditions, and by extension, increases the severity and increase a likelihood of death. And there's similarities across the data sources in the studies as to the relationship between pre-existing comorbidities and fatality. So what I'm doing next here is just bringing up a few studies that have been showing globally what are the trends that are being seen. In the American Journal of Infection Control, there was a rapid review of current literature, and they looked at about 27 articles, and they reviewed which covered about 22,700 patients. And the highlights of that study was that one or more comorbidity is highly prevalent in severe and fatal COVID-19 cases. The caveat to that, though, is that the definition that they've been using for one or more comorbidity is that once there's more than one line in terms of conditions written on a death certificate, which could in some cases include symptoms which really may be directly related to COVID-19. Hypertension is the most prevalent comorbidity seen in COVID-19 populations, and no clear association exists between COVID-19 mortality and comorbidity. We look briefly at the pictures. Again, we see hypertension is the top, cardiovascular, diabetes, chronic obstructive pulmonary disease. And these, again, as you see in this list, these are our chronic diseases. When we look at a similar study that was done on deaths in New York, where there was a hotspot for in terms of the pandemic, we see again similar percentages. We're seeing 55.4% in hypertension, hypertension being in the top, diabetes next, and again, a similar profile, just that the percentages are higher. We look at a similar study that was done on patients in Italy. Again, we know that was another hotspot, and again, similar, hypertension, diabetes, ischemic heart disease, all within the top 5. If you look down the list, again, a lot of the items here are chronic diseases. And just to give a little highlight in terms of terms of risk, among persons in this particular study, the MMWR outlined, you had 19.5% of the persons died had underlying conditions, and 1.6% without underlying conditions. And by implication, this is what they, were able to draw. The deaths were 12 times higher among patients with reported underlying conditions compared with those without reported underlying conditions. This again shows that if you break it down by age group, you can have different things highlighted at different age groups. Obesity for the 0 to 24. However, for the 85 plus, you're seeing vascular and specified dementia. Again, that being something that you see with the elderly. But just to highlight something here, that there was that in the studies, while there was an overrepresentation of, say, hypertension, for example, among hospitalized, it is still uncertain whether this relationship is causal or confounded by age and other comorbidities associated with hypertension. including obesity, diabetes mellitus, and chronic kidney disease. Yeah. Cause is concerned, of course, because the prevalence of hypertension in the Caribbean, as we know, is affecting between 21% and 38% of persons in these countries that I have listed here. And also too, in other studies, they've shown the prevalence of diabetes to be affecting between 17.8% and 14 and as low as 11.7 in these particular countries listed here. But what it shows here that we have high prevalence of these diseases and therefore need to be concerned. I'm touching a little bit here on certification of COVID-19. That's mainly because the information that we talk about, that we look at, that are reviewed, for example, the source of that information are generally from your death certificates. And so the information on your death certificate is really key. If it's inaccurate, our data will be likewise inaccurate. And just to recap, in terms of your death certificate, the underlying cause of death is really key here. When it's completed, it's the disease or injury that started the train of morbid events leading directly to death. And so in the case of COVID-19, for example, it's saying that the underlying cause is COVID-19, and as a result, that has led to the series of conditions that you will see that follow. And I'll give an example as we go. The physician's responsibility is really to indicate the course of events, decide directly what is the condition responsible for death, and then determine what are the antecedent conditions that are going to give rise to the immediate cause. This is an example of a certificate with COVID-19. So if you notice, COVID-19 led to pneumonia, which led to acute respiratory distress syndrome. But look where the comorbidities are placed. They're placed in the significant conditions. And this is why I brought this slide up, because I want those of us who are in the audience, those persons in the audience who know and are often responsible for completing these death certificates, that we would really implore them to include this information and to include it in the second part, the significant others, and to give the time, because this would greatly help in our research and understanding going forward of what's happening in the region. But just to point out that not all persons who have died with having been positive for COVID-19 are COVID-19 deaths. So you can have a situation here where you have a motor vehicular accident and it has led to aortic dissection, hypovolemic shock, but it is not a COVID-19 death. COVID-19 may have exacerbated it, and we are asking physicians to please put it in part 2. Again, this will all contribute to research. And this is another example here where COVID-19 is not necessarily the cause of death. And so these are the examples of the misclassification I spoke about, but that is important in understanding and in terms of making and giving us confidence in the accuracy of our data. The last couple of slides here, as I begin to wrap up, the additional, in terms of the WHO classification for diseases, which is what is used as a standard in understanding and in looking at the information and analyzing the information that comes out of death data. They have provided codes for having a history of COVID-19 and for post-COVID-19 conditions, as well as the multi-system inflammatory syndrome. So again, I brought this up to make sure that you remember to record this information, because it can be coded and is going to be used for the analysis. We also have specific code for suspect, if the virus has not been identified, but it's probable or suspected, and a different code for the virus identified. And so we're imploring that physicians actually record when they have a COVID-19 death that the case is confirmed. Finally, the global effort to characterize and evaluate and manage this epidemic continues. We have some clarity on vulnerable groups or who might have increased risk for acquiring COVID-19. However, more studies and evidence need to be gathered especially for the Caribbean. And with that, I end. Thank you very much. Handing over to you, Colin.
Thank you, Angela. Thank you for breaking down those statistics for us and helping us to understand current trends, especially within the context of COVID-19. May I remind you to place any questions that you may have into the Q&A at any time during the webinar. Panelists, you may respond directly into the chat. We'll also have a chance to have further discussion during our Q&A segment at the end of the presentations. It is now my pleasure to invite Dr. Trevor Ferguson to provide insights on COVID-19 and cardiovascular disease, a Caribbean perspective. Dr. Ferguson is a senior lecturer in epidemiology and director of the Epidemiology Research Unit, Caribbean Institute for Health Research at the University of the West Indies, Mona. He's also honorary consultant in general internal medicine in the Department of Medicine at the University Hospital. Dr. Ferguson is part of the Chronic Disease Research Group at the Epidemiology Research Unit. He conducts research and he holds research grants in the fields of cardiovascular disease epidemiology and diabetes, with a particular interest in the etiology of hypertension and risk factors for cardiovascular disease. His work has also focused on diabetes complications, in particular diabetic foot problems, cardiovascular disease, and chronic kidney disease. We feel very honored to have Dr. Ferguson with us this evening, and I now invite you, Dr. Ferguson, please address us.
Okay, good afternoon, everyone. Let me try to share my screen. CARPHA webinar. Okay, where is my presentation? Oh. All right, just a moment. All right, let's close that again, sorry. Let me see, are you able to see the screen at this time?
Yes, we are.
Okay, good.
You should probably just put it on slideshow though, and we'll
Yes, I will be doing that in a moment.
Okay, good, we're seeing.
All right, good. Are you able to see well now?
Yes, we are.
Okay, so good afternoon. Sorry about that bit of a delay. Let me first thank CARPHA for inviting me to participate in this seminar. Certainly, I think it is timely. And of course, looking at COVID-19 and its effect on NCDs, and also the issues related to stroke risk, is of particular importance. So for this presentation, I'll be speaking about COVID-19 and cardiovascular disease from a Caribbean perspective. Now, most of us are very well aware that COVID-19 is one of the greatest public health emergencies of modern times. It is believed that not since the 1918 influenza pandemic has the world suffered so great a health crisis. And up to October 27, 2020, there was over 44 million cases and over 1.1 million deaths. Now, we're also very well aware that severe viral pneumonia leading to acute respiratory distress syndrome is the hallmark of the disease. But it also has become quite apparent that cardiovascular manifestations are an important component of COVID-19. Now, pre-existing cardiovascular disease is a major predictor of severe disease as well as severe mortality. And COVID-19 has also been shown to have a large impact on access to care and care-seeking behavior among persons with cardiovascular diseases, therefore leading to an indirect increase in both morbidity and mortality. Now, with regards to cardiovascular disease in patients with COVID-19, as we previously mentioned, there's a high prevalence of pre-existing cardiovascular disease and cardiovascular risk factors among patients with COVID-19. And these particular cardiovascular disease risk factors include hypertension, diabetes mellitus, as well as obesity. COVID-19 itself may lead to cardiovascular disease, including myocardial injury, arrhythmias, acute coronary syndrome, and venous thromboembolism. Some children with COVID-19 develop a hyperinflammatory syndrome similar to Kawasaki's disease. Now, with regards to the prevalence of cardiovascular disease risk factors in COVID-19, a number of studies have been published. And in this slide, we summarize some of the findings, mainly from studies in China, but also with some data from Italy, and the United States. So with regards to cardiovascular disease overall, in China, the prevalence ranged from about 2.5% to 15%, and in the US, in the region of 11 to 14%. And as we can see from the numbers in brackets, that among persons who required mechanical ventilation or those with more severe disease, that the prevalence of cardiovascular disease was significantly higher than seen among persons with, all persons with COVID-19. When we look at hypertension, again, we see a prevalence ranging from 15% in this study in China to a high as almost 57% among persons in the United States. And again, we see among the studies in China that the prevalence was higher among those with more severe disease. Diabetes prevalence was approximately 5.3% from this study in China, up to 34% among persons in the United States. And obesity, emerging as another major risk factor, particularly among younger persons, was seen in about 36 to 42% of persons in the United States. Now, in terms of the mechanisms by which COVID-19 leads to cardiovascular disease, it is thought that this may be due in part to the high burden of systemic inflammation that is induced in COVID-19, that much of the damage may be due to this systemic inflammatory response. However, the particular receptor that facilitates the entry of the COVID-19 virus into the cells is the angiotensin converting enzyme 2. And this particular enzyme is found on the cell surfaces in several of, certainly the lungs, as well as in several cardiac and vascular tissue. And it is thought that the ACE2 may play an important role in the pathophysiology of COVID-19. And in this illustration, we see here, this is the S protein of the coronavirus, which binds to ACE2, and this facilitates the entry of the virus into the cell. Now, Nishiga and colleagues suggested that there may be a bidirectional relationship between COVID-19 and cardiovascular disease. And what this shows is that, firstly, as we mentioned, that cardiovascular disease morbidity increases the susceptibility and severity of the disease. So we're here in this corner where persons with hypertension, coronary artery disease, or diabetes may have more severe disease and may be more susceptible to COVID-19 overall. Now, additionally, the systemic inflammation that is induced by COVID-19 may cause myocardial injury, increase the risk of arrhythmias, as well as causing acute coronary thrombosis and also venous thromboembolism and cardiac arrhythmias. Additionally, drugs may play a role in that the drugs that are used in the treatment of COVID-19 may increase the risk of arrhythmias. And there is some debate as to whether some drugs used in cardiovascular disease may increase or decrease the risk of COVID-19. So there is a significant interplay between several factors in terms of cardiovascular disease increasing risk and susceptibility, but COVID-19 itself also having significant impact on the cardiovascular system. So just to look at some of the conditions in a little bit more detail, and firstly, hypertension. So as we saw from the previous slides, that hypertension occurs very frequently among persons with COVID-19, and also that it's more frequent among those with adverse outcomes. However, it is thought that the association between hypertension and the risk of severe complications or death is really confounded by the lack of adjustment for age and comorbidities. And the European Society of Cardiology, in their guidance on managing cardiovascular disease in COVID-19, suggested that at present there is no evidence that hypertension per se is an independent risk factor for severe complications or death. Now, additionally, and this was a point of major controversy early in the epidemic, is that evidence from recently published studies suggest that prior or current treatment with ACE inhibitors or angiotensin receptor blockers does not increase the risk of COVID-19 infection or the risk of developing severe complications. And therefore, patients with these conditions should continue taking their drugs unless there are other reasons why this may be discontinued. In general, they recommend that persons with hypertension follow existing recommendations, and of course that persons who with COVID-19 and are in isolation would not need to come in for routine visits. Additionally, though, one point of note is that there may be an increased risk of arrhythmias due to hypokalemia associated with COVID-19, and that's certainly something that will need to be borne in mind in our hypertensive patients. With regards to myocardial injury, acute myocardial injury has been demonstrated based on increase in the cardiac troponins as well as ECG abnormalities, and this has been seen in 7 to 20% of patients with COVID-19. Now, it is thought that myocardial injury is associated with a worse prognosis, and one study found that there was a 5-fold increase in the risk for mechanical ventilation and an 11-fold increase in the risk of death. Now, predictors of myocardial injury include older age and the presence of comorbid conditions, as well as the presence of inflammatory markers such as increased levels of CRP. Whether or not a true myocarditis occurs is still uncertain. While there have been case reports, the studies have not yet identified the SARS-CoV genome in cardiac tissue. All right, so moving on to acute coronary syndromes. Now, COVID-19 can trigger acute coronary syndrome, and this has been demonstrated in a number of studies. In a case series from New York, there were 18 patients with COVID-19 and ST segment elevation. 6 of these were confirmed to have myocardial infarction, and 5 required percutaneous coronary intervention. In another case series from Italy, there were 28 patients with COVID-19 and ST segment elevation, and of those, 17 required percutaneous coronary intervention. The overall incidence, however, of acute coronary syndrome in COVID-19 remains unknown, and the potential mechanisms include plaque rupture, coronary spasm, the presence of microthrombi due to systemic inflammation, as well as complications related to the cytokine storm and endothelial injury. Now, in terms of heart failure, this has been found to be a frequent complication of COVID-19. And in one study from Wuhan, in which there were 799 patients, 24% had heart failure. And among those who died, 49% had heart failure. There has been demonstrated elevations of pro-BNP in up to 49% of 19 and as much as 85% of those who died. And of course, pro-BNP is a marker for cardiac injury and suggests heart failure in patients who presents with shortness of breath and other similar symptoms. Now, the etiology of heart failure in COVID-19 may be multifactorial. It may be related to pre-existing cardiovascular disease, may be related to factors such as tachyarrhythmias, excessive hydration, renal impairment, as well as acute myocardial injury or acute coronary syndrome from COVID-19. And in severe cases, it's thought that there may also be stress-induced cardiomyopathy, as well as cytokine-related myocardial dysfunction. With regards to arrhythmias, this is another important area where several patients present sometimes with palpitations. Arrhythmias have been reported in about 17% of patients in one study, and as much as 44% of patients in the intensive care unit. Persons with elevated troponins are more likely to have malignant tachyarrhythmias, such as ventricular tachycardia or ventricular fibrillation. Studies have noted both in-hospital and out-of-hospital sudden cardiac arrest, and of course, the arrhythmias may be due to direct myocardial injury or to other complications related to COVID-19. Now, lastly, in terms of the complications, COVID-19 is associated with a hypercoagulable state, and there is increase in the levels of fibrinogen, increase in D-dimers, as well as a modest elevation of the PT and PTT. There is sometimes mild thrombocytosis or thrombocytopenia, and some patients have a positive lupus anticoagulant. Now, based on this hypercoagulable state, the risk of venous thrombosis is very high in up to 43% of patients in the intensive care unit. And in addition, some patients have been found to have microvascular thrombosis. There's also increased risk of arterial thrombosis, leading to stroke, myocardial ischemia, as well as limb ischemia. Again, the underlying mechanisms are unclear, but it is thought that this may be related to the inflammatory response or to endothelial dysfunction. And of note, patients in hospital should receive prophylactic or therapeutic anticoagulation based on their overall clinical status. So that summarizes the overall cardiac manifestations of COVID-19. What does this mean for Caribbean populations? Now, that cardiovascular disease remain the leading cause of death in the Caribbean. And this slide, though rather dated, shows that cardiovascular disease is accounted for 4 of the 5 leading causes of death in the Caribbean in 2004. Now, additionally, we have shown very high prevalence of hypertension and other cardiovascular disease risk factors, and this was highlighted in the previous talk as well. And here, this is looking at prevalence of hypertension among persons 25 years and older, ranging from about 40% to 47% in the various Caribbean countries. This is looking at some data from the Jamaica Health and Lifestyle Surveys from 2001 to 2017. And what is striking is that there's been increase in essentially all the cardiovascular risk factors over this period. And overall, 54% of persons were overweight or obese. Obesity itself, approximately 29%. 32% with hypertension, 10% with diabetes, and 17% with high cholesterol. We have also shown that there are a significant proportion of persons who have reported pre-existent heart attacks, and this is higher among the older persons. Of course, this represents survivors and doesn't give us a true picture of the total burden of heart disease. Prevalence of stroke is also of significance, and again, reaching as high as about 7% among persons 75 and older. When we looked at overall heart disease by self-report in the Jamaica Health and Lifestyle Survey 3, 2.5% of persons reported some type of heart disease, and just under 1% reported a diagnosis of heart failure. Now, with regards to the cardiovascular disease and COVID-19, I was able to get a little bit of information from the Ministry of Health, and we want to express our gratitude to the team there. What we are able to say so far is that among the participants who died, the majority were over 60 years, that is 72%. 46% had some type of cardiovascular disease, including hypertension. 37% had diabetes, 6% had neurological diseases, and 5% were obese, although I presume that this obesity is underreported. But here we're seeing with these basic data that cardiovascular disease remain a major factor among persons with COVID-19. So what does all of this mean? Now, when we in the Caribbean, to date, the pandemic has been less severe than compared to USA or Europe. But we have also seen that in these countries, there have been severe strain on the health system, resulting in severe staff limitations, as well limitations in ICU beds. Now, when we look at our capacity in the Caribbean to deal with these types of emergencies, we are severely limited. And although some contingency measures have been put in place, which may result in some improvements, we still lack the ability to respond to large inflows of patients with cardiac or pulmonary complications as a result of COVID-19. Therefore, our focus must remain on public health measures to contain the spread of disease, and we continue to encourage physical distancing, universal mask wearing, and importantly, appropriate PPE for health workers. We also need to ensure that health workers are trained and kept up to date with the rapidly changing literature on COVID-19. And of course, in the Caribbean, we need to participate in research to document the Caribbean experience and therefore contribute to the global knowledge as it relates to COVID-19. So we'll stop there, and well, we'll come back to this at the end. Thank you very much.
Thank you, Dr. Ferguson. Thank you so much for that very sobering information. And that call in the end for the need for more research. Thank you so much for that. You're listening to the CARPHA Health Wrongs webinar, Under Pressure, NCDs and COVID Part 2, Vulnerable Populations, as we seek to raise awareness on stroke today, World Stroke Day. Our next presenter is Mrs. Sharmaine E. Edwards. Mrs. Edwards is well qualified to speak with us on nutrition and cardiovascular disease and COVID-19. As she holds a Master of Science degree in Human Nutrition from the Tropical Medicine Research Institute, now Caribbean Institute for Health Research at the University of the West Indies. She has also been a registered nutritionist since 1997, and she's very passionate about nutrition. Mrs. Edwards has authored and co-authored scholarly papers. She's published in which have been published in international and regional journals, and she's presented at regional and international conferences. Mrs. Edwards has served on several technical committees, both locally and internationally, and has served as the Vice President of the Caribbean Association of Nutritionists and Dietitians. Mrs. Edwards is a member of the American Academy of Nutrition and Dietetics and the Director of Nutrition in the Ministry of Health and Wellness, Jamaica. I now invite Mrs. Edwards to address you.
Thank you for that introduction, and I'd like to thank CARPHA for this invitation. I am going to share my screen, and I am also hoping that I can do this presentation in the allotted time. So my presentation is going to be on nutrition, CVDs, and COVID-19. So Dr. Ferguson has taken us through pretty much of what COVID brings to us and some of what the CVDs bring to us. But in terms of an outline for this presentation, I want to take a brief look at a definition and some risk factors for cardiovascular diseases or disorders, COVID-19, a definition and risk factor, and as I said, brief, nutrition and infection, and how it links with cardiovascular diseases and COVID-19, look at a few nutrition support strategies, and then I'll conclude. Now, you have heard this in the previous presentation, but just to remind us that cardiovascular diseases are majority of conditions that affect heart and blood vessels. They're the leading cause of death and disability, certainly in the Caribbean, but also globally. And you know, these conditions include the hypertension, the diabetes, insulin resistance, and dyslipidemias. What I want to say about the hypertension, though, is that it's a leading risk factor for coronary heart disease, for stroke, for congestive heart failure, and for chronic renal failure. So you see the breadth of reach for hypertension. Now, what are the risk factors? They're mostly environmental and lifestyle related. And the common ones we know is a diet of refined foods and low physical activity levels. What that brings us are obesity, smoking, diet, and mental health. And you might wonder, why is mental health there? But mental health has a massive cycle, because if you have these conditions, you tend to get depression sometimes. And there's a spin-off on that as well. If you are depressed, you can also get these conditions, because then you're going to pick up those lifestyles that you really don't want. All right, and we know about those comfort foods. This slide is showing the life cycle of the SARS-CoV-2 virus. And Dr. Ferguson had this slide, of course, in more detail, so I'm not going to spend much time on it, other than to say that COVID-19 is a disease which is caused by the severe acute respiratory syndrome coronavirus type 2, known as SARS-CoV-2. The patients usually present with fever and respiratory symptoms, gastrointestinal symptoms. It primarily affects the respiratory tract, and there's also some multi-organ failure, which can lead to fatalities. And I'll show you in a bit why I'm mentioning these symptoms. The risk factors, and Dr. Ferguson mentioned a number of studies that have been conducted and ones that highlight the pre-existing conditions as causal, and some that do not. However, what we find is, and he showed you the data, that in immunocompromised persons, they tended to have more severe cases of the COVID-19 infection. And some of these persons include our older adults, persons with polymorbidities, so more than one, and of course, their nutritional status was compromised. So, with that, how does nutrition affect infection? We have immune cells all over our body, as you can see, and you know where they are, all right? Now, there is a complex interaction. So, an infection can affect the person's nutritional status, as well as the nutritional status can affect the rate and type of infection. Both the infection and the nutritional status of the individual is going to lead to or can impact on the cell-mediated response. And Dr. Ferguson told us all about that, all right? And can, of course, lead to uncontrolled inflammation, which then can further impair or enhance the type of infection that the individual will have. Now, the immunocompromised patients, we spoke about the level of the nutritional status, obesity, and of course, the elderly. Now, if we take a little more closer look at how nutrition affects infection, nutrition can change the risk for acquiring the infection. As I said, it can affect the pathogen entry and it can affect the cell-mediated response. I won't mention the vaccine because we're not at that point as yet. Nutritional status can also change morbidity because it can regulate oxidative stress and inflammation. It can, if it is in a good state, reduce pathogen virulence, and it can also impact the microbiome, which is inside the individual or the host in this case. Now, if we are to look at the role of nutrition in management of conditions, the goals of nutritional management really include enhancing nutritional intake to counteract any hypermetabolic state. We want to maintain flexible approaches as well, because each individual is different and you want to ensure that you're meeting individual preferences. We also want to ensure that we are boosting the immune system by supporting the diet with adequate antioxidants and nutrient-dense foods. And of course, we have to manage the underlying comorbidities because we have to look at the whole person. So in our field as nutritionists and dietitians, we use what we call the ADIME system. We look at their nutrition assessment because we have to look at what is it that we are in fact going to be treating with. Is it the obesity or is it the dehydration? So we have to make that nutrition assessment to know what it is that we are going to prioritize in terms of what do we tackle first. Having done the assessment, then we come up with our diagnosis. With that diagnosis, then we know how we are going to intervene. And that intervention includes monitoring and evaluation on a continuous basis, and possibly changing the approach that is taken. Now, Dr. Ferguson also mentioned the effect of COVID-19 infection. And I just want to highlight these ones that are a part of the cytokine storm that have nutrition implications. So, insulin resistance, all right? Volume overload, because then there's going to be need for conservative fluid resuscitation. He mentioned the hyponatremia, hypocalcemia, hyperphosphatemia, hypertriglyceridemia. There's a hyperinflammatory response, which have implications for our enzymes, our liver enzymes, our heart proteins, or C-reactive proteins. There is rapid persistent refractory hypoxemic respiratory failure, and I'll show you in the next slide where this comes in. And of course, there's some amount of immobilization and accelerated proteolysis. So what does that mean? Some of these situations are deterrents to nutrition intervention. First of all, there's a loss of taste and smell. And we know what that means. If you can't smell the food, then you're not going to taste it. These persons are ill, so they're going to have poor appetite. They might be coughing, so that's going to have an impact on their swallowing. Some persons are going to be on ventilation. How do you interrupt that ventilation to allow for feeding? So there is also a fear for aspiration. If you insert an NG tube, it is going to break the seal on the positive air pressure. If we give parenteral nutrition, it can affect the hypertriglyceridemia as well as the hyperglycemia. these persons might also have some amount of risk for refeeding when we start on enteral feeds. So if you look at what the patient with COVID-19 is undergoing and what nutrition interventions are going to be required, we have a challenge. We know that good nutrition is important before, during, and after an infection, because the infections themselves are going to take a toll on the body, especially if there's presence of fever. And we know that that has been listed as one of the common symptoms of COVID-19. The body is going to need extra energy and nutrients. And so we have to ensure that during COVID, we are maintaining our healthy diet. We don't have any magic food that is going to prevent it, but we need to ensure that we have a supporting immune system. So what is this healthy diet that we are talking about? We've heard them. Most of our countries in the Caribbean have their food-based dietary guidelines, and so does Jamaica. And generally speaking, the healthy diet speaks about a variety of foods from the food groups that are specific to the Caribbean, not just across groups, but also within groups. We want to ensure that our diet is low in fat, so we don't have the risk of developing those chronic diseases and cardiovascular disorders that were mentioned. We want to ensure that we are low in salt and sodium, and we know the recommendations for that. We want to ensure that sodium chloride that we are intaking is less than 5 grams or less than a teaspoon per day. We want to ensure that we are having complex as opposed to refined carbohydrates. What are these complex carbohydrates? They're usually based on plant sources. So we don't want the ones that, yes, they come from plant sources, but then we go into a factory or into a lab and we try to quote unquote enhance its flavor and so on. We want to have processed foods in a low form. So we don't want to be having products from cans on a regular basis. We want to ensure that we are eating fresh, because fresh is better. And so we need fresh fruits and vegetables. In our last lifestyle survey in Jamaica and previous lifestyle surveys, and the trend is similar in the Caribbean region, we have an abundance of fruits and vegetables. But when it comes to consuming them, we are not doing so great on that. What you're seeing here is a depiction of the Jamaican food-based dietary guidelines. And you can see the 6 groups of importance to the Caribbean. We see our vegetables and our fruits, and you notice how much of the plate that should take up. And this is in terms of not caloric contribution, but grams. So it's amount of food. We have our staple foods, and we know them, and all of them are tasty. We have a variety that we can choose from. We have our foods from animals, and we have our legumes and nuts that we really don't consume a lot of. And then a little slithering of fats and oils, because fats and oils are still very important in our diet. So alcohol, because we love to take a little tat, as my father would call it. But alcohol, drinking it does not protect against COVID-19. Yes, it's good for the hand sanitizers and so on, but certainly not for ingestion, all right? Because we know that excessive alcohol consumption increases immediate risk of injury, as well as causing longer term effects like the liver damage, the cancer, the heart disease, and mental illness. And of course, we need to know what it is that we are putting in our bodies. So we have to ensure that whenever we have interaction with clients, or even for us ourselves, we need to be reading those labels. We need to be looking at what it is that we are putting into our bodies. Currently, CARICOM is trying to finalize a front of pack labeling, and we're having a very difficult time because our producers and manufacturers are fighting against what it is that we need to help our populations in the Caribbean to choose wisely. Because sometimes we don't really have the time to be looking at the details. We want a quick reference so we can put a front of pack warning symbol to say, okay, this one is not so good, this one is not so good. Because we have very, 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 very active lifestyles in terms of we are always on the move, all right? And so we need to have things at our fingertips. So for a healthy lifestyle and a healthy diet, that's what I want to mention. Now, having said that, how do we support what is required for our COVID-19 and CVD clients? We recommend up to 6 meals a day. What does these include? 3 main meals and 2 to 3 snacks daily. No person said, why we have to eat 6 times, all right? But it's easier on the system. During illness, nutritional requirements are not met because we tend not to eat at that time, but we need to ensure that they're getting adequate protein for preserving and improving muscle mass, all right? They need to ensure that their fluid intake is maintained so that they can regulate that body temperature and of course help to rid waste. Winding down, foods, I spoke about the canned and highly processed food that we need to minimize, all right, and anything high in sodium. But again, as I mentioned before, the meals should meet individual, not just requirements, but preferences. And that's FAO's definition of food security. It must meet individual preferences. So in concluding, a healthy lifestyle will make all bodily functions work better, including our immunity. Eating healthy diets with plenty of fruits and vegetables are key. Dr. Ferguson mentioned an important point, and I smiled when I heard it because I knew I had it here. Our health system response is going to need strengthening because some of them are already strained, and this COVID-19 and the resources that are required to deal with it is going to make it worse. And so we need to ensure that we are prepared from an individual perspective, especially our patients that are already immunocompromised. That healthy diet is going to be critical. Not smoking, exercising regularly, getting adequate sleep, and minimizing and coping with stress, because stress makes us eat all those nice foods that make us feel well. And then these are my sources. So thank you for listening.
Thank you, Mrs. Edwards. Thank you for reminding us about the importance of paying particular attention to what we put into our bodies and the importance of maintaining a healthy lifestyle, especially in relation to cardiovascular disease during times of COVID. Thank you so much.
Sure. I'm trying to get back to unshare.
Last but certainly not least, I'm pleased to introduce to you yet another expert panelist, Dr. Tamu Davidson, who will discuss the exercise prescription. Dr. Davidson is head of the Chronic Disease and Injury Department at CARPHA. Before joining the agency, Dr. Davidson worked as a medical doctor and public health specialist for a combined 24 years in both urban and rural Jamaica at every level of the health system. She's held several positions, including medical intern, physician research assistant, sickle cell unit UE, district medical officer, HIV/AIDS support group facilitator, medical officer of health, regional HIV/AIDS STI program coordinator, acting regional technical director, Southeast Regional Health Authority, medical epidemiologist, chronic diseases and injuries, and director, disease prevention and control. Dr. Davidson is also a past lecturer in epidemiology and non-communicable diseases at the School of Public Health and Health Technology, University of Technology, Jamaica. Ladies and gentlemen, I'm pleased to introduce to you Dr. Tamu Davidson.
Just give me a moment, get the slides going. Okay, good evening, everyone. So hopefully you're still with us. I have the pleasure of being the last presenter today. And today we're going to look at the global mandate physical activity versus exercise, health benefits of physical activity, exercise prescription, and we're going to talk a little about COVID-19 and physical activity. And so this is the basic outline of my presentation for today. So just a reminder for everybody that we do have our global mandates and both regional mandates with respect to physical activity. Our main global mandate is to reduce physical activity by 10% by 2025 and by 2030 by 2030 by 15%. And the baseline year for this is 2010, just a year before the first global political mandate on non-communicable diseases. We also have in 2018 a global action plan on physical activity. So we do have some key global mandates that we have agreed on, including our own regional mandate, which is the Port of Spain Declaration on NCDs. Now, physical activity is any bodily movement produced by skeletal muscles that require energy expenditure. And so what is exercise? Exercise is a subcategory of physical activity that's planned, structured, repetitive, and aims to improve or maintain one or more components of physical fitness. So if we look at physical activity, any sort of physical activity reaps benefits. And so there are many health benefits from doing physical activity. The first health benefit, which is quite immediate, is really improving in your cognition, your thinking, reduced short-term feeling of anxiety, stress, improved sleep. It also helps with thinking, learning with sharp judgment skills as well. It also helps to reduce and lower the risk of death from cardiovascular disease, hypertension, type 2 diabetes. It improves your blood lipid profile. It also helps to prevent some cancers such as breast, colon, endometrial, cancer of the esophagus, kidney, lung, and stomach. And it also causes a reduction in all-cause mortality. It improves your sleep. It improves quality of life. It can reduce the risk of dementia, including Alzheimer's, improve cognition in older adults, and reduces symptoms of anxiety and depression. But physical activity can also help to control or in the management and treatment of many common non-communicable diseases. These include type 2 diabetes, hypertension, dyslipidemia, osteoarthritis, dementia, and multiple sclerosis. It also improves abstinence from smoking. There's research to finds that physical activity can improve one's abstinence for persons who are trying to quit smoking. It also improves weight management, which is maintaining weight at a healthy level, and also weight loss for those persons who are overweight and obese. It improves the physical functioning, bone health, and also fall prevention. So there is a myriad of strong evidence around the benefit of physical activity to health. So in this particular research that was shared, it looked at the estimated population attributable fraction by WHO region. And essentially, it tells us that by eliminating physical inactivity, how much could we prevent? And here you will look at Latin America and the Caribbean has the highest estimated population attributable fraction for all-cause mortality, for coronary heart disease, diabetes, breast cancer, colorectal cancer, and also the highest in terms of gain in life expectancy, both Latin America and Western Pacific. And these two areas have high prevalence of physical inactivity as well. And this estimated benefit is actually higher than all the regions combined. So looking closer to home, if we look at the same study and we look at countries within our region, we see here that Barbados and Jamaica, if they eliminate physical inactivity, they could prevent Jamaica 12.8% of all-cause mortality, Barbados 12.5% of all-cause mortality, which is even higher than the Latin American and the Caribbean region combined, and higher than all regions. So we know that in really addressing physical inactivity and increasing physical activity, we can really impact on general overall death, all-cause mortality, but also on reducing these chronic conditions such as coronary heart disease, diabetes, breast cancer, and colon cancer. And in fact, breast and colon cancer are the highest in terms of the effect of eliminating physical inactivity. We also can see the gain in life expectancy years is highest also for Barbados, which is about 0.91. And this figure may look low, but this gain in life expectancy years is really looks at the population in a general sense, both those who are inactive and active. If we were supposed to take out those who, if we took out those who were inactive, we would see a higher gain in life expectancy. But certainly this is significant for the region, where Jamaica is 1 and Barbados is 0.91. So the benefits of physical activity are well established. Physical activity can be used to treat, prevent, and manage non-communicable diseases. An exercise prescription is a specific plan of physical activity designed for a specific purpose, and in this case, to improve health and well-being. So prescribing physical activity should be a part of routine patient care in a primary care setting and other settings, but the focus of today is in primary care. So exercise prescription is like any other prescription. So when, as a physician, or as we prescribe or drugs, routine medication, tablets, we look at the type, the dose, the frequency, duration, and then we look at what the therapeutic goal is. And it's a similar approach to looking at exercise prescription. And in exercise prescription, we apply what we call the FIT principle. And that really is frequency. We look at how often per week one will perform the exercise. We look at intensity, how hard a person works to do the activity. We look at time, duration, which is the length of time in which an activity or exercise performed in minutes. And then we look at type mode. So we look at modes of exercise, aerobic. We look at aerobic exercise. We look at resistance. We look at flexibility and balance. So before prescribing a physical activity program, it's important that anyone embarking on that program, and also for the healthcare provider, the physician or doctor who is prescribing the program, that screening, you do screening to identify cardiovascular risk factors, because this can have an adverse outcome for the person who may engage in physical activity, who may be sedentary, who may have many risks. And so it's important to screen for these risk factors and also to do a full medical assessment as well. Some of the screening tools that you use to do this assessment include the Physical Activity Readiness Questionnaire, or the PARQ. And this questionnaire is really a brief 7-item questionnaire where you answer yes or no, looking at a series of risks with respect to cardiovascular disease. And then there's also another common questionnaire that's used, which is a fitness facility pre-participation screening questionnaire, which further goes on to look at symptoms related to cardiovascular disease. And so the most common one that's used in practice is the PARQ, which is really quick and easy to administer. So based on these screening results, then you would stratify persons into 3 groups. You stratify them into low risk, moderate risk, and high risk. So low risk would be men over 45, less than 45 years, and women less than 55 years with no more than 1 cardiovascular risk. For moderate risk, it would be men over 45 years and women over 45 years with 2 or more risk factors. And high risk, any individual with known cardiovascular, pulmonary, or metabolic disease or demonstrate signs or symptoms of cardiovascular disease. So in assessing and screening patients prior to embarking on a physical activity regime, what's important and what we know what works and works in fact in other areas is a brief intervention, what we call brief counseling. And the 5 A's are used in counseling on nutrition, is used in the area of tobacco control, is used in the area of alcohol. And this is really a quick assessment that's done. So you want to first start by asking, so you want to ask the patient, question like, in the past week, how many days have you been physically active for a total of 30 minutes or more? And so that you would start the conversation just exploring whether they're in fact engaging in any sort of physical activity. Then you want to assess. So you want to assess the patient's current physical activity level and what is their willingness to change. So, where are they are they thinking about it? Is it something that they've not thought about, something that they're really not interested in? It may be that they'll have to come back to really engage them in this discussion about becoming physically active, because they may not be at the stage where they're even contemplating or even interested in engaging in physical activity. And then you want to advise. You want to discuss risk and benefits of exercise. You want to look at risk stratification, further assessment around if necessary. So once you've done their risk stratification and assess them using the PARQ questionnaire and other tests that you may have on your patient and the physical assessment that you have done, you want to see whether if they're at high risk, you may need to refer them to do further investigations. And then if they're not at risk and they can move on to look at discussing an exercise regime, then you want to go into looking at assist and agreeing. So you want to assist and agree. So you want to provide the patient with various techniques to motivate and give them the self-confidence to actually engage in physical activity. Some of the things may be to look at, a starting point. What do they like to do? Start small. It may be they've never been exercising, so they start 2 days a week. Maybe start with just something as simple as 5 minutes per day. Usually we say 10 minutes, but if they're very, very busy, have them start somewhere so that they can build their confidence to build on their exercise regime. So if the patient is willing and ready to start a program, then you need to agree on some targets and activities. And so that should be discussed with the patient. In some settings, they set up a contract. The patient may write themselves a little contract saying, this is how much physical activity I'm going to do for the day, and I'm going to do it at this time on this day. And then you want to arrange for follow-up so that you can see how well they're progressing. And then you want to refer if you realize that this patient may need further assistance, not someone really motivated, may not be able to on their own, based on your interface with the patient, engage or begin to initiate physical activity, then you may want to refer to a specialist, such as an exercise specialist or so, to speak with them and help to support this process. And then when they're follow-up, you want to look at some of their successes and challenges. So in writing prescription, exercise prescription, you want to look at the frequency, how many times per week will the patient perform the exercise. So you plan on most days of the week. You want to look at that intensity, how hard should the person work to do the activity. So a moderate intensity in exercise, they can talk but not sing during the activity, and vigorous intensity, they can say a few more words without pausing for a breath. And then you want to look at the time. So you want to look at how long. And so in your prescription. So you want to start with as little time as needed. And typically that's 10 minutes. It may be even less for the person who's just starting out and has never exercised and fully sedentary. And then you want to look at a type. So you want to look at a type of activity and this you will identify with the patient, and you look at what is enjoyable, affordable, and achievable. Typically, I usually recommend walking because that is usually one of the easiest and most affordable ones for many persons. And you can walk in your home. They don't have to walk outside or on the street or on the road. Some of the, it can be just coming off your bus stop a little bit earlier and walking a distance home. And then you want to refer as necessary to exercise and fitness professionals and follow up by appointment. So you want to have a written prescription and a prescription pad that you can hand to the patient is usually one of the best practices and for them. So this is just an example of exercise prescription for someone who has cardiac, who wants to become physically active. And you may start out with walking at a conversational pace, 5 days per week, 10-minute session. And then you look after 4 weeks, how well they're tolerating it. And as they go along, you want to build on that. So the next session, 4 weeks later, they will increase it from 10 minutes to 15 minutes once they tolerate it. And then you go from 15 minutes to 30 minutes, and then you introduce strength training after they've been able to tolerate this. And if they're not tolerating it, then you really want to reassess them and do a cardiac evaluation on such a patient. But the important point is a gradual increase in physical activity over time. So this, just to share with you, this is a global recommendation for physical activity for the 3 age group categories. This is actually under review, and WHO is actually doing consultation on a new set of guidelines to come out for 2020, I think 2021, and they've already started their consultation. But this highlights the importance of doing vigorous intensity activity daily for 60 minutes for those 5 to 17 years old. For those 18 to 64, that's 150 minutes to 75 minutes of vigorous aerobic activity. And for those 65 years and older, a similar recommendation. However, if you're not able to do the recommended amounts of physical activity, it's encouraged that whatever you can do, your ability allows you to do, you should be moving. The main important thing is doing even a little physical activity can improve your overall health and well-being. So there are several barriers that healthcare providers have highlighted why they're unable to implement this exercise prescription: lack of time, lack of or inadequate access to guidelines to support them in actually implementing this. Lack of buy-in from staff and patients who don't really buy into this different approach. It may take a longer time in the initial stage with your consultation with the patient, and inadequate resources, including exercise and other professionals to support the services, have been some of the barriers. This is just to quickly share that really physical activity on prescription schemes, this is from different countries, the study which looked at different interventions throughout globally implementing exercise prescription. And they varied from country, but most of them were focused on prescribing for persons with chronic illnesses, and they utilize GPs, nurses, and other healthcare professionals. They were a mix of both facility and home-based prescriptions. So this type of approach to physical activity as a part of not only prevention, but also treatment is not a new phenomenon. And just to highlight that in the Caribbean region, we looked at the scorecard that was done looking at the NCD progress report by PAHO, and we found that almost most of the Caribbean countries were implementing at least a national public awareness program on physical activity. And so there should be a heightened awareness about the importance of physical activity in general. Of course, the challenge is that really to sustain the physical activity. And I want to share this intervention, which was done in Trinidad and Tobago, which looked at exercise prescription given by GPs to persons with attending chronic disease clinics in the health centers. And here you see that they had about 106 patients in the intervention group. Sorry. They had 106 patients in the intervention group, which were counseled for about 1 to 2 minutes individually about the benefit of exercise, after which a written prescription was provided by the GP. And as you can see here, the intervention group by far sustained their physical activity at 1 and 3 months post-intervention in comparison to the non-intervention group. And so it emphasizes the importance of exercise prescription and that it is possible within our region to implement. I just want to highlight here that looking at COVID-19 and physical activity, with many of the public health measures to prevent COVID, such as stay-at-home orders, curfews, the closure of gyms, sports, and recreational facilities, or with even the reopening and limiting the number of persons in the facilities, there was a concern about the decline in physical activity overall. But I just want to share some preliminary findings out of a study in Jamaica, which looked at older adults. And 74.4%, which is the majority, reported no change in their physical activity levels since the stay-at-home order in the pandemic. Not shown here, there's also over 10% of those who actually reported increasing their activity. So what we found during the pandemic, there was a lot of innovation to deliver physical activity, virtual 5Ks. There were also persons moving to a virtual environment to offer aerobic classes, to offer swimming, to offer dance. And in fact, it opened a door for many persons who may have used not been having time to go somewhere to become physically active or not being able to engage in their favorite type of activity. It opened a door for more persons to participate in physical activity. And also persons' anecdotal evidence suggests that they had more time to engage in physical activity during lockdown, which they could schedule around their work time. And also, physical activity has been promoted as a key tool to help cope with the pandemic and to improve mental health and well-being. So I just would like to end with some key take-home points that we need to start looking at physical activity as a vital sign. So for every patient that comes in to your health facility or who is seen at a health facility, just like how we take the blood pressure, we need to be asking about their physical activity. The health benefits of physical activity are well established, and exercise prescriptions should be integrated as a part of the standard prevention and treatment guidelines for persons with NCDs in the primary care setting and even other settings. Physical activity is a tool to help cope with the COVID-19 pandemic, improving mental health and well-being and reducing stress. And time well spent is an investment in future patient encounters. Exercise is medicine. Thank you.
Thank you, Dr. Davidson. Thank you so much. Another essential in the prescription to prevent and manage cardiovascular disease, exercise, or some form of physical activity. Thank you. We are at the question and answer segment. I noted that our panelists have been responding to questions within the Q&A. We may have already addressed them all. I will wait a few seconds or so to see if anyone would like to may probably have a question but did not put it in the Q&A. But I think that I have noted that our panelists have been responding to questions. So thank you for that, panelists. We are about half an hour or so over our time. So perhaps it may be a good idea for me to invite our panelists to provide a brief summary or to give us key takeaway messages this evening. I will continue to monitor the Q&A just in case someone has a question that they did not put in there. But we can go to Perhaps I would like to invite Dr. Ferguson to start us off with your key takeaway message this evening. Dr. Ferguson, I invite you to start us off this evening.
Thank you, Ms. Curtin. So just to probably summarize the main ideas, all of us are very aware that COVID-19 remains a grave health to global public health. And while we recognize that severe pneumonia and respiratory failure are the most serious manifestations of COVID-19, there are several major cardiovascular complications. We remember or we note that pre-existing cardiovascular disease is associated with higher risk of complications, as well as increased mortality from COVID-19, and that COVID-19 itself may lead to myocardial injury, myocarditis, acute coronary syndrome, heart failure, cardiac arrhythmias, thrombosis, and a number of other complications. And taking all of this into consideration, it's important that we continue to maintain preventive measures to contain the virus so that we can mitigate against the negative effects of COVID-19. So I hope that was 1 minute or less.
I think so. Thank you so much, Dr. Ferguson. We can now go to Mrs. Edwards.
Okay, thank you. What I want to say is that we have a fair amount of undernutrition globally, and certainly it's no different in the Caribbean, where 1 in 3 persons have hidden hunger, and we don't hear a lot about that. That is our micronutrient deficiencies. We hear about iron deficiency, but we have not addressed all the others, the zinc, the selenium, the vitamin D, which is one we are now questioning, and of course, vitamin C. We also know that obesity is an issue. And so with the COVID-19, we saw higher lethality. And we also know that the global elderly is growing. So we are having an increased elderly population. We also know that COVID-19 is threatening food security and nutrition for millions of people, from the point of view that persons are losing their jobs, and so they're no longer food secure because they can't access food. So they are purchasing cheap calories at the expense of nutrient-rich foods. So we have that side. So we need to just practice our healthy dietary habits to maintain our physical and mental health. And of course, stress, we need to reduce that. And we don't know how we're going to do it in this time, but that's my takeaway. Thank you.
Thank you, Mrs. Edwards. I now invite Mrs. Hinds to give us a brief summary and some takeaways.
Thanks, Garland. The reality is the data is showing that those persons with certain chronic diseases, such as hypertension, cardiovascular diseases, obesity, are at risk for a severe outcome of death. And we need to recognize this. And based on the feature speakers that have spoken, we need to take home and we need to take charge of our health, because at the end of the day, we are really risking our health. We have seen from the data that the prevalence of these diseases are high. Nutrition is going to be important, exercise is important, and understanding the disease that we have, that if any of us have or suffering from, we need to address it and not ignore it and walk and hope it will go away. It is impacting on our health and it is increasing our risk. And that's my takeaway message.
Thank you, Mrs. Hinds. I know Dr. Davidson just finished her presentation, and you did give us some takeaways, but just for emphasis, Dr. Davidson, would you like to provide some key takeaways once more?
Yes, so I just want to highlight that I don't want us to forget about the importance of physical activity, not just to promote health, good health, but also in the treatment and management of NCDs. The evidence is overwhelming on the general health benefit in all aspects of health. There's good evidence, and there's good evidence to show that we can prevent death, all-cause mortality due to physical activity. And so it is important that physical activity is just like any vital sign, and that we're asking about it when our patient encounters, just like how we take our blood pressure routinely on all patients. We should be asking about physical activity, and it needs to be integrated in every aspect of care. And so it's important that we remember it during COVID times, and that it can in fact help us to cope with the pandemic. And physical activity can take place anywhere. We only need to do some physical activity, and more is better. Thank you.
Thank you, Dr. Davidson. Dr. St. John, I invite you to give us a takeaway message as well. Is Dr. St. John on?
Yes, I am.
Okay, great.
It takes me a while to find the buttons. So you're allowing me to give a takeaway message?
Please.
I think I want to tell the panelists how pleased I am with a really good, full of information webinar. It was wonderful to listen to. And I want to tell the participants that COVID is a beast.
Mm-hmm.
And we've just had a really good presentation about all the ways in which this thing is dangerous for our health. So first of all, let's try to prevent contracting and spreading. And second of all, with the good information that you've just received, try to make your life healthier. I've started walking. I was really interested because the same way in which Tamu said, start small and build up, that's the same way that I did it. Try to make your life healthier. And also the last thing I want to say is have a really good night and stay safe.
Thank you so much, Dr. St. John. I concur. We have come to the end of another successful Health Rounds webinar. If we were unable to provide an answer to your question, or if you think of something that you want to post to any of the panelists, please email us at postmaster@carpha.org. That is postmaster@carpha.org. I want to assure you that we will respond to you in a timely manner. But all good things must come to an end. A sincere thank you to all for your participation and for staying the course with us. Special thanks to our presenters this evening, Dr. Joy St. John, Executive Director, CARPHA, Mrs. Angela Hinds, and Dr. Tamu Davidson, also of CARPHA. Thank you, Dr. Ferguson and Mrs. Edwards, for sharing your expertise and for providing insights into these critical areas of cardiovascular disease and COVID-19. Thank you so much to our participants who have taken the time to be with us this evening. No doubt you have benefited from the information shared. I would like to encourage you to complete a brief evaluation of this evening's webinar, which you will receive tomorrow, so look out for it in your inboxes. Also, look out for the next webinar in the Health Rounds, where we will discuss preparing for COVID-19 vaccine safety surveillance. You really wouldn't want to miss out on that next Thursday, November 5th, as we all eagerly look forward to a safe and effective vaccine. Again, thank you, and do have a good evening and also a good night. Thank you, everyone.
Thank you.
Thank you. Thank you. Thank you.
Bye.
Bye.
Bye-bye.
Have we ended it?
Bye all. Thank you very much.
Bye. YouTube has ended.